Welcome. With this session, we'll start our discussion of Rhegmatogenous retinal detachment, and in this session, we'll be discussing about the retinal lesions which predispose to Rhegmatogenous retinal detachment, the associated risk factors, and the principles of prophylactic treatment of these lesions in high-risk eyes in order to prevent Rhegmatogenous retinal detachment. Rhegmatogenous retinal detachment, or RRD, is an important cause of visual loss and blindness, and the term rhegmatogenous arises from rhegma, which means break or tear in Greek. And so, rhegmatogenous retinal detachment is a retinal detachment which arises from a retinal break. It has been found that following initial surgery for rhegmatogenous retinal detachment, 10 to 20% of detached retina remain detached, and following repeat surgical procedure for detached retina, 5% of retina still remain detached, and visual acuity of 20/50 or better is achieved in only 50% of eyes following retinal reattachment procedures. So prophylaxis against RRD is an important consideration, but no randomized clinical trial has been conducted to assess the therapeutic value of prophylactic treatment in reducing the risk of RRD. The pathogenetic sequence of RRD is as follows. In this diagram, the red line represents the retina, the brown line represents the choroid, and the blue line represents the vitreous cortex. The strongest adhesion between the vitreous and the retina is at the vitreous base, as shown here in this diagram. So the first event in the pathogenesis of RRD is liquefaction of the vitreous. Following liquefaction of vitreous, the posterior vitreous detaches from the retina, and this is called posterior vitreous detachment. And in as many as 25% of eyes with acute PVD, the process of PVD is incomplete, as a result of which there is continued risk of retinal tears occurring in future. There are no prophylactic measures against these initial two steps in the pathogenetic sequence of RRD. Following PVD, there is vitreoretinal traction, that is, the vitreous cortex pulls on the retina at the site of vitreoretinal adhesion, causing a retinal break. And prophylactic measures which can reduce this vitreoretinal traction include vitrectomy and scleral buckling, which we will be discussing in subsequent sessions, and which, being surgical procedures, have their attendant risks. Following the occurrence of the retinal break, liquefied vitreous in the retrohyaloid space passes through the retinal break into the subretinal space, which is a potential space between the neurosensory retina and the RPE and choroid, resulting in detachment of the neurosensory retina. The subretinal fluid can migrate more posteriorly in the subretinal space, thus resulting in extension of the retinal detachment, which can occur up to the margin of the optic disc. Prior to entry of the liquefied vitreous into the subretinal space, creation of adhesion between the RPE, choroid, and the neurosensory retina all around the break with either laser or cryo can prevent the occurrence of rhegmatogenous retinal detachment, and this is the most commonly employed method of prophylaxis against RRD, which we'll be discussing later in this session. So we'll start by enumerating the risk factors for retinal detachment and then describe the lesions predisposing towards rhegmatogenous retinal detachment. Then we'll take up individual clinical scenarios, namely symptomatic eyes with high risk of RRD, symptomatic eyes with low risk of RRD, asymptomatic eyes with low risk of RRD, and asymptomatic eyes with high risk of RRD. The risk factors for retinal detachment include symptoms and signs of acute PVD, which include photopsias and increased floaters, and the incidence of PVD is increased in myopic eyes in older individuals following ocular surgery such as pseudophakia, aphakia, and NDA capsulotomy, and following ocular trauma. We'll be discussing about traumatic retinal breaks and traumatic retinal detachments in a separate session. And in comparison to an eye with a history of prior complete PVD without a retinal break occurring, an asymptomatic eye with an attached vitreous is at a much higher future risk of RRD, as this attached vitreous can detach later in life, and during this process of vitreous detachment from the retina, the risk of retinal break and RRD arises. Retinal breaks with vitreous attached to the retinal break such that the vitreous pulls on the retinal break, as in horseshoe tear and retinal dialysis, have a higher risk of subsequent RRD occurring, whereas atrophic holes only infrequently lead to RRD, and lesions which increase the risk of retinal break occurring include lattice degeneration, cystic retinal tufts, meridional folds, and degenerative retinoschisis. And as a group, they are known as precursor or predisposing lesions, which increase the risk of retinal break. Other risk factors for RRD include history of RRD in contralateral eye, family history of RRD, hereditary vitreoretinopathies such as Stickler syndrome, inflammatory entities such as acute retinal necrosis and CMV retinitis, male gender, and ocular trauma. Among the predisposing lesions, we have retinal breaks, which are discontinuities in the neurosensate retina, and precursor lesions, which increase the risk of retinal breaks. Retinal breaks, as seen here in these two photographs, are full thickness discontinuities in the neurosensate retina, which may allow liquefied vitreous to pass into the subretinal space, as we have discussed. And retinal breaks can be retinal tears, which occur due to vitreoretinal traction, as seen here in this color photograph, or retinal holes, which occur due to retinal thinning in the absence of vitreoretinal traction, as seen here in this photograph. These terminologies, retinal breaks and its two types, retinal tears and retinal holes, are important to note. Prevalence of retinal breaks in the general population has been estimated to be around 10%, but annual incidence of RRD has been estimated to be only 12 per 100,000 individuals, and so most retinal breaks do not lead to RRD, and this is important to remember and is the reason why only few retinal breaks are treated, as we shall see in this session. Incidence of retinal breaks increases with age, but males and females are affected equally. Although the risk of RRD is similar among retinal breaks occurring in different quadrants, risk of macula of RRD, in which the macular retina is detached, is higher with superotemporal retinal breaks as compared to inferior or nasal retinal breaks, and risk of RRD is considered to be higher with larger retinal breaks. Certain systemic or genetic conditions may predispose to retinal breaks, such as hereditary vitreoretinopathies such as Stickler syndrome, Marfan syndrome, Ehlers-Danlos syndrome, and homocystinuria. Long-standing retinal breaks, whether retinal tears or retinal holes, have RP changes surrounding them, as seen here in this color photograph, which indicate chorioretinal adhesion and thus decrease the risk of RRD extending from these breaks. The different types of retinal breaks include horseshoe tears, giant retinal tears, operculated retinal tears, atrophic holes, and retinal dialysis. Horseshoe-shaped tears, also known as flap tears or HSTs, as seen here in these two color photographs, occur when vitreoretinal traction pulls a strip or flap of retina anteriorly without detaching this strip from the remainder of the retina. The posterior edge of an HST is called its apex, and its anterior margin is called its base. As we have described, HSTs typically occur at the posterior border of the vitreous base, where the vitreous is most firmly attached to the retina, and this is very important to remember. In this photograph, we see a localized zone of subretinal fluid surrounding the HST, and in this photograph we find a lattice degeneration lesion at whose lateral margin the HST has occurred. A giant retinal tear is a retinal tear which also occurs due to vitreoretinal traction but extends 90 degrees or 3 clock hours or more circumferentially, and this also takes place along the posterior border of the vitreous base. In this photograph, this is the torn edge of the retina, and this is the portion of the retina which has flipped over itself, and this is the portion of the fundus where the RP choroid is directly visible and so is commonly called bare choroid. An operculated retinal break can occur when vitreoretinal traction is able to detach a portion of the retina entirely from the surrounding retina at the base of an HST, leaving a small round break in the neurosensate retina and an operculum of retinal tissue floating in the vitreous cavity just above the retinal break. After the operculum gets detached from the retinal break, there may or may not be vitreoretinal traction around the retinal break. Persistent vitreoretinal traction at an operculated break can be diagnosed when major ocular movements cause only a minor movement of the operculum, because that suggests adhesion of the vitreous to the retina around the retinal break. Atrophic holes are commonly found within lattice degeneration lesions, as seen here in this clinical photograph. but may also occur in an otherwise normal appearing zone of the retina. And atrophic holes are known to cause slowly progressing RRD in young myopic patients even in the absence of posterior vitreous detachment, and this is important to remember. A retinal dialysis is a circumferential linear retinal break occurring at the ora serrata as seen here in this color photograph, and as the break is at the ora serrata, there is no retinal tissue anterior to a retinal dialysis. This is in contrast to the other retinal breaks in which the full thickness defect in the neurosensor retina is located posterior to the ora serrata, and in a retinal dialysis, the vitreous base remains attached to the retina posterior to the break, and this is in contrast to horseshoe tear in which the vitreous base remains attached anterior to the HST. Then we have the precursor lesions which increase the risk of retinal break and thus RRD, and these include lattice degeneration, cystic retinal tufts, meridional folds, and retinoschisis. There are other peripheral retinal degenerations, but they do not increase the risk of retinal break or RRD, and we'll be discussing them at the end of this session. Lattice degenerations, as seen here in this clinical photograph, are considered as vitreoretinal interface abnormalities appearing as well-defined oval or linear areas of retinal thinning. Some of these lesions may have crisscrossing fine white lines called lattice lines, as seen here in this clinical photograph, from where the name lattice originates. Lattice lesions may have hyperpigmentation as seen here in this photograph, hypopigmentation as seen here in this photograph, and as we have described, round atrophic holes within their boundaries. And blood vessels traversing through a lattice lesions appear sheathed. And histopathology of lattice degeneration lesions, as seen here in this B scan, consists of thinning or atrophy of inner retinal layers, liquefaction of overlying vitreous, and tight vitreoretinal adhesions at the edges of the lattice lesion. Lattice degeneration lesions occur in 8% of general population, an important figure to remember, but is found much more frequently in myopic eyes, in eyes with RRD, and in eyes of individuals having family members with lattice degenerations. And in individuals who have lattice degenerations, the lattice degeneration lesions are bilateral in up to 50% of such individuals. 25% of lattice degenerations are associated with retinal breaks, as seen here in this clinical photograph. But most retinal breaks associated with lattice degenerations do not proceed to RRD, and two types of retinal breaks have been associated with lattice degenerations, one being tractional retinal tears, which occurs due to vitreoretinal traction, and these typically occur at the posterior and lateral edges of the lattice degeneration, as seen here in this clinical photograph, because as we have mentioned, the vitreous is tightly adherent to the retina at the edges of the lattice degeneration, and this is important to remember. And as we have mentioned earlier, round atrophic holes may occur in the thin retina within the lattice degeneration and are not associated with vitreous traction. And as we have discussed earlier, atrophic holes can cause slowly progressing RRD, particularly in young myopic eyes, even with an attached posterior vitreous. Snail track degeneration, as seen here in this clinical photograph, is considered as a variant or early stage of lattice degeneration and appears as groups of glistening white dots. Histopathologically, snail track degeneration is similar to lattice degeneration. Cystic retinal tufts are small focal elevated areas of glial proliferation in the peripheral retina and are easily missed if the peripheral retina is not examined with scleral depression. They are often associated with vitreous or zonular attachment and traction and may infrequently lead to RRD. A meridional fold is a radially oriented fold of redundant retina extending posteriorly from the ora serrata, usually from a dentate process. Sometimes this fold of retina may extend anteriorly into the pars plana, be aligned with the fold of pars plicata when it is called a meridional complex. Meridional folds are typically found in the supraornasal retina, and tractional retinal tears can occur at the posterior limit of a meridional fold. Retinal tears can also occur at the posterior margin of an enclosed oral bay, an example of which has been shown here in this photograph, and at a peripheral retinal excavation, as seen here in this photograph. Degenerative retinoschisis, as seen here in this clinical photograph, is a splitting of the neurosensory retina into two leaflets, as seen here in this OCTB scan. The retinoschisis appears as a relatively thin and transparent elevation of the retina, which, unlike an RRD, does not move with ocular movements. Degenerative retinoschisis, most commonly and initially, involves the infratemporal quadrants bilaterally, and retinal breaks occurring in both the inner and outer leaflets of a retinoschisis can lead to RRD. Before going into the individual clinical scenarios, we'll describe certain terms which we will use. A symptomatic eye is an eye which has symptoms of photopsias and/or increased floaters, and an asymptomatic eye is an eye which does not have these symptoms. A fellow eye is an eye with an attached retina whose contralateral eye has an RRD or a history of RRD, and a non-phakic eye is an eye which has undergone cataract surgery and is either pseudophakic or aphakic. To summarize our discussion of these individual clinical scenarios, a symptomatic eye having a retinal break with vitreoretinal traction is a definitive indication of prompt prophylactic treatment because of high risk of subsequent RRD, and precursor lesions in non-phakic, that is pseudophakic or aphakic fellow eyes, is recommended. Eyes perceiving photopsia or flashes and/or increased floaters associated with acute PVD are considered as symptomatic and have an increased risk of RRD. Photopsias or flashes occur due to vitreous traction on the retina, and floaters occur due to blood, glial cells torn from the optic nerve head, or aggregated collagen fibers in the vitreous cavity, casting shadow on the retina. Only symptomatic eyes having tractional retinal tears are considered to be at high risk of RRD and needs to be promptly treated. But as we shall see later, in the absence of tractional retinal tears, symptomatic eyes with acute PVD do not require prompt prophylactic treatment even in the presence of non-tractional retinal breaks or precursor lesions. Only 15% of symptomatic eyes have been found to have a tractional retinal tear at initial examination, but the risk of presence of retinal tear in a symptomatic eye increases with the presence of vitreous hemorrhage, including its amount, and also the presence of pigmented cells in the vitreous cavity, and this is very important to remember. Vitreous hemorrhage arises from either avulsion of superficial retinal or peripapillary blood vessels or rupture of blood vessels crossing the retinal tear, and pigmented cells in the vitreous cavity or even in the anterior chamber are dislodged RPE cells migrating to the vitreous cavity through the retinal tear. Prophylactic treatment in symptomatic eyes is indicated when these eyes are found to have a tractional retinal tear with persistent vitreoretinal traction on these tears, and these include HSTs and operculated retinal breaks with persistent vitreoretinal traction. HSTs with persistent vitreoretinal traction have a very high risk of progressing to RRD without treatment, but the risk of progression to RRD decreases dramatically following treatment. So HSTs with persistent vitreoretinal traction need to be urgently treated. Similarly, operculated retinal breaks with vitreoretinal traction need to be promptly treated. Symptomatic eyes with low risk of retinal detachment include eyes with non-tractional retinal breaks and eyes with vitreoretinal precursors in the absence of a tractional retinal tear. Non-tractional retinal breaks include operculated retinal break without vitreoretinal traction and atrophic retinal holes which do not require treatment. Symptomatic eyes with vitreoretinal precursors of retinal break and RRD, such as lattice degeneration, cystic retinal tufts, and degenerative retinoschisis, are not routinely treated, and the need for treatment is based on presence of additional risk factors as considered for asymptomatic eyes with these lesions and additional risk factors which we will be discussing. Vitreoretinal precursors in asymptomatic eyes are considered to have a low risk of progression to RRD and so are not usually treated. This study by Bayer et al. Was a landmark study which found that clinical RRD occurred in 0.7% of phakic non-fellow eyes with lattice degeneration over 11 years of average follow-up, while symptomatic tractional retinal tears occurred in 1.4% of these eyes. but atrophic retinal holes within lattice degeneration occurred in a much larger proportion of eyes. So, as lattice degeneration in asymptomatic eyes have a low risk of progression to RRD, lattice degeneration in these eyes do not require treatment in the absence of additional risk factors. Similarly, since only 0.3% of eyes with cystic retinal tufts progress to RRD, cystic retinal tufts do not require treatment in asymptomatic eyes. Also, since only 2.2% of eyes with degenerative retinoschisis have been found to progress to RRD over a period of 14 years, treatment is indicated only when subretinal fluid progresses behind the equator in an eye with retinoschisis having breaks in both leaflets of the retinoschisis. In another report, Bayer et al. Described the fate of 235 phakic non-fellow eyes with asymptomatic retinal breaks followed up for an average period of 11 years. Out of these 235 eyes, 45 eyes had a horseshoe tear at initial examination. Acute PVD occurred in some of these eyes during follow-up, but in none of these eyes acute PVD altered any of the existing breaks. 3 of these eyes with acute PVD had new breaks which were treated. And although subclinical RRD occurred in 8% of these eyes, fluid progressed in only 1.3% of these eyes to require treatment. Subclinical RRD refers to extension of subretinal fluid beyond one disc diameter from the margin of the retinal break but not posterior to the equator. So asymptomatic retinal breaks, including even HSTs, do not require prompt treatment, but these breaks need to be followed up carefully as they may occasionally lead to slowly progressive RRD. Broad et al. Observed 31 eyes with asymptomatic or subclinical RRD without treatment for a mean of 3.4 years and found that only 2 eyes progressed to symptomatic RRD. Even then, treatment of subclinical RRD is frequently recommended. Risk of progression from subclinical RRD to clinical RRD decreases further when a demarcation line forms around the subclinical RRD, although progression through demarcation line has been documented. As we have discussed earlier in this session, factors which increase the risk of RRD in both asymptomatic and symptomatic eyes include myopia, history of cataract surgery, family history of RRD, and history of RRD in the contralateral eye. Although the incidence of retinal breaks in myopic eyes has been found to be similar to the general population, 42% of all phakic RRDs have been found to occur in myopic eyes, and the risk of RRD has been found to increase with the degree of myopia, but individuals with myopia as low as 1 diopter have also been found to have an increased risk of RRD. As we have mentioned earlier, lattice degeneration is more common in myopic eyes than in the general population, and most slowly progressing RRD from atrophic holes in lattice degeneration occur in young myopic eyes. Still, there appears to be no increased benefit of prophylactic treatment of lattice degeneration in myopic phakic non-fellow eyes. Cystic retinal tufts and degenerative retinoschisis are not more common in myopic eyes, and prophylactic treatment of these lesions are not indicated in myopic phakic non-fellow eyes. Asymptomatic retinal breaks in myopic phakic non-fellow eyes rarely lead to RRDs, and so prophylactic treatment of these lesions are not indicated in these eyes. Aphakia and pseudophakia increase the risk of RRD, and this is said to be because of forward shift of vitreous causing vitreous traction on the peripheral retina. Pseudophakia has been found to increase the risk of RRD fourfold, and another study found that the risk of RRD was greatest in the first year following cataract surgery but remained higher even after 20 years following cataract surgery. An intact posterior capsule reduces the risk of RRD compared to an eye with disrupted posterior capsule, and NDA capsulotomy increases the risk of RRD, which has been estimated to be 0.5% in the first year following capsulotomy. Benefit of prophylactic treatment of precursor lesions in non-phakic non-fellow eyes is not known and so is not advised, and similarly no firm guidelines are there for prophylactic treatment of asymptomatic retinal breaks in non-phakic non-fellow eyes, including eye schedule for cataract surgery. Prophylactic therapy is clearly indicated in fellow eyes of patients with hereditary vitreoretinopathies such as Stickler syndrome, but otherwise there is no clear indication for prophylactic treatment of predisposing lesions in non-fellow eyes in patients with family history of RRD. As we have mentioned, vitreoretinal precursor lesions such as lattice degeneration frequently occur bilaterally, and RRD occurring in one eye called the primary eye increases the risk of RRD in the fellow eye by up to 40%. We'll first discuss about phakic fellow eyes and then about non-phakic fellow eyes. In another landmark study, Folk et al. Evaluated phakic fellow eyes with lattice degeneration for a mean of 8 years after RRD in the primary eye and found that new retinal tears without RRD developed in only 5.7% of untreated phakic fellow eyes and in 3% of treated phakic fellow eyes, and new retinal tears with RRD developed in only 5.1% of untreated phakic fellow eyes and 1.8% of untreated phakic fellow eyes. The reduction in the risk of RRD in treated phakic fellow eyes was small but statistically significant in all subgroups except eyes with 6 diopters of myopia or more and for high myopic eyes with more than 6 clock hours of lattice degeneration. And remarkably, 30% of all new tears in treated phakic fellow eyes were outside the areas of treated lattice degeneration. Similarly, Bayer et al. Estimated that 58% of all RRDs in eyes with lattice degeneration were from breaks occurring in areas without lattice degeneration or other vitreoretinal abnormalities. For these reasons, some suggest prophylactic treatment of the entire peripheral retina in these eyes, but Bayer's further analysis concluded that such a treatment is both ineffective in preventing the risk of RRD and may also aggravate vitreoretinal traction. And Davis showed that no phakic fellow eyes with an existing PVD developed RRD, but 13% of such eyes without an existing PVD developed RRD on follow-up. So prophylactic treatment of lattice degeneration is considered to be of little value for phakic fellow eyes with lattice degeneration because incidence of RRD in such eyes is low even without treatment. New retinal tears often occur away from the lattice degeneration lesions, and because prophylactic treatment in eyes with extensive lattice degeneration and or high myopia has not been found to be effective. But prophylactic treatment of asymptomatic phakic fellow eyes should be considered when the result of RRD surgery in the primary eye was poor, patient is unable to recognize the symptoms of acute PVD, and patient lives in an area where prompt treatment when symptoms arise is not available. For cystic retinal tufts in phakic fellow eyes, there is no data regarding efficacy of prophylactic treatment. Degenerative retinoschisis is frequently bilateral, and treatment of degenerative retinoschisis in phakic fellow eyes is indicated if the primary eye developed RRD from an outer layer tear within the retinoschisis area and the phakic fellow eye has an outer layer tear within the retinoschisis area. Meridional et al. Detected retinal breaks in 19% of phakic fellow eyes, and 15% of phakic fellow eyes with retinal breaks progressed to RRD, and HSTs were the causative factor in 71% of phakic fellow eyes which progressed to RRD. And among the 85% of phakic fellow eyes which did not progress to RRD, only 19% of breaks were HSTs. So in the absence of requisite data, HST in asymptomatic phakic fellow eye should be treated. Freeman et al. Reported new giant retinal tears in 4.4% of untreated fellow eyes of patients with giant retinal tears in the primary eye, and Wolfensberger et al. Reported that following 360-degree prophylactic cryotherapy of the fellow eye in patients with giant retinal tears in the primary eye, giant retinal tear occurred in 2.1% of these treated fellow eyes. So prophylactic treatment of phakic fellow eyes in patients with giant retinal tears in their primary eyes is frequently recommended, and there is compelling evidence for such treatment in patients with Stickler syndrome, which we have described in the previous session. Then we come to non-phakic fellow eyes. As with phakic eyes, these two studies showed that in non-phakic fellow eyes with pre-existing PVD, the risk of future RRD is much less than in non-phakic fellow eyes with an attached vitreous. In the absence of supportive data, lattice degenerations in asymptomatic non-phakic fellow eyes or fellow eyes scheduled to undergo cataract surgery is frequently recommended, and the treatment recommendation for cystic retinal tufts and degenerative retinoschisis for non-phakic fellow eyes is similar to those in phakic fellow eyes. Davis found that RRD occurred in 50% of aphakic fellow eyes with asymptomatic retinal breaks, and most of these occurred from HSTs. Benson et al. Reported that among fellow eyes with lattice degeneration undergoing cataract surgery, 30% of eyes whose lattice degenerations were not treated prior to cataract surgery developed RRD, while 18% of eyes whose lattice degenerations were treated prior to cataract surgery developed RRD. So treatment is recommended for HST in asymptomatic non-phakic fellow eyes and fellow eyes scheduled to undergo cataract surgery. As with phakic fellow eyes of primary eyes with giant retinal tears, prophylactic treatment of non-phakic fellow eyes of primary eyes with giant retinal tears is recommended, and so is eyes with Stickler syndrome. Prophylactic treatment of 360 degrees of peripheral retina during certain vitreoretinal procedures has been recommended despite the absence of definitive prospective data, and these vitreoretinal procedures include silicone oil removal, vitrectomy for a non-RRD indication such as macular hole, and pneumatic retinopexy. Prophylactic treatment entails creating chorioretinal adhesion around retinal breaks and vitreoretinal precursor lesions deemed to be at significant risk of progression to RRD with minimum energy application and precise control of location of application. Treatment should be applied in attached retina all around the lesion, immediately adjacent to it, or its associated subretinal fluid if present. For an HST, treatment must include the retina anterior to the tear up to the vitreous base, and this is very important to remember. Prophylactic treatment can be performed with either cryotherapy or laser photocoagulation, and both are considered equally effective, but one may be preferred over the other in certain clinical scenarios, which we will discuss. Rarely scleral buckling, which reduces vitreoretinal traction, may be used for prophylaxis of RRD. Cryotherapy involves freezing the choroid and retina in the same location and is applied with a cryoprobe, usually transconjunctivally, with visualization of the treatment site with an indirect ophthalmoscope and a condensing lens. Unlike laser photocoagulation, cryotherapy is particularly useful for very anterior locations and in eyes with mild to moderate media haze, either from cataract or vitreous hemorrhage. Partial chorioretinal adhesion following cryotherapy takes 5 to 7 days to occur, and full effect requires up to 3 weeks. Under topical and/or subconjunctival anesthesia, the active tip of the cryoprobe is held perpendicular to the globe and in direct contact with it at the site of application. Patient is asked to rotate the eye towards the meridian of application, and the cryoprobe is made to indent the globe at the site of application under visualization through an indirect ophthalmoscope. Foot switch of the cryo machine is then applied, and freezing is allowed to occur till a visible grayish-white reaction is detected in the retina at the site of application, involving 2 mm of attached retina adjacent to the lesion as seen here in this photograph. Then, without disturbing the view through the indirect ophthalmoscope, the cryoprobe is applied to an adjacent area and freezing re-initiated, and this ensures that treatment is confluent and completely surrounds the lesion being treated, and also reduces skip lesions and refreezing of the same location. And as we have already mentioned, adequate treatment is particularly important at anterior margin of HST, where vitreous traction is present and likely to extend the break, and also at posterior and lateral margins of lattice degenerations, where new retinal tears are likely to occur. Regions of exposed RPE in the center of large retinal breaks should not be treated to reduce dislodging and dispersing RPE cells into the vitreous cavity. Disadvantages of cryotherapy include inability to treat far posterior lesions transconjunctivally, occurrence of skip areas between two adjacent application sites, or refreezing of the same site, as it is more difficult to appreciate the extent of each application with cryo as compared with laser. Adequate choroidal adhesion takes more time to occur with cryo as compared with laser. Dispersion of viable RPE cells into the vitreous cavity, disruption of blood-retina barrier, and cryo over long ciliary nerves impair accommodation for weeks to months. Postoperative conjunctival swelling and hemorrhages are common after cryotherapy, and some patients may need to maintain bed rest, often with bilateral patching to reduce ocular movements for 5 days, as adequate choroidal adhesion following cryotherapy may take that long. Laser photocoagulation can be applied with a slit lamp and a contact lens, as seen here in this photograph, and this is particularly preferred for posterior locations of the retina, or with an indirect ophthalmoscope and a condensing lens, as seen here in this photograph, which is preferred for anterior locations. Along with indirect ophthalmoscope, scleral depression may be used, and then the laser spot is applied at the crest of the indented area. But very anterior locations may not be accessible even with an indirect ophthalmoscope and scleral depression. Unlike cryotherapy, partial choroidal adhesion following laser photocoagulation occurs almost immediately within 24 hours, but like cryotherapy, full effect requires up to 3 weeks to take place. Laser photocoagulation can be usually performed under topical anesthesia, but some patients may require retrobulbar anesthesia. A 500 to 1000 micron zone of burns is created all around the lesion, and usually 3 to 4 rows of burns are required. Either a grid application or a continuous application can be used, and with a grid treatment, the space between the burns should not be more than 1/2 burn width. With slit lamp delivery, a spot size of 200 to 500 microns is selected, but with indirect ophthalmoscope, the spot size is pre-selected at the machine, but the burn size can be varied by selecting condensing lens of a specific dioptric power. The spot duration is usually 100 milliseconds to 150 milliseconds, and shorter the spot duration, less the discomfort for the patient. Power of the laser is titrated by increasing power from a low power setting till an adequate burn intensity of gray-white is obtained. And as with cryotherapy, adequate treatment is particularly important at anterior margin of HST and posterior and lateral margins of lattice degeneration. Postoperative activity restriction following laser photocoagulation is similar as for cryotherapy, but a shorter duration is acceptable. Advantages of laser photocoagulation include visible, localized and immediate reaction at the treated site, and so it is easier to judge the intensity and extent of each application with laser photocoagulation as compared to that with cryotherapy. Creation of a partial choroidal adhesion within 24 hours with laser photocoagulation as compared to that with cryotherapy, and the zone of the retinal break with bare RPE can be more efficiently avoided during laser photocoagulation, thus further reducing the dispersion of RPE cells. Disadvantages of laser photocoagulation includes requirement of a clear media and adequate visualization of the area to be treated, and so laser application may be difficult in eyes with small pupil, cataract and vitreous hemorrhage. Very anterior lesions may not be accessible for laser photocoagulation. Excessive laser burns can cause rupture of Bruch's membrane, choroidal hemorrhage and retinal tear, disruption of blood-retina barrier, but less than that with cryotherapy, and occurrence of corneal and lens burns. Although scleral buckling neutralizes vitreoretinal traction, it is rarely used for prophylaxis against RRD, and indications for scleral buckling as prophylaxis against RRD include progressive subclinical RRD and extensive vitreoretinal precursor lesions. We'll be discussing about scleral buckling procedure in a later session. This is probably the most important slide in this video. Definitive indication for prophylactic therapy include acute symptomatic retinal tears such as horseshoe tear, operculated break or subclinical RRD with vitreoretinal traction, and hereditary vitreoretinopathies such as Stickler syndrome. Strongly recommended indications for prophylactic therapy include HST in asymptomatic non-phakic fellow eyes and asymptomatic non-phakic fellow eyes of primary eyes with non-traumatic giant retinal tears. We may note here that like RRD, treatment of giant retinal tear and retinal dialysis is primarily surgical repair and not prophylactic. And this is a list of frequently recommended indications for prophylactic therapy, and these include HST or subclinical RRD in fellow eyes or primary eyes with giant retinal tears, lattice degenerations in symptomatic eyes, lattice degenerations in non-phakic fellow eyes, lattice degenerations in phakic fellow eyes under certain extenuating circumstances, and along with certain vitreoretinal procedures. Complications of prophylactic therapy with either laser or cryo include failure of treatment, which usually occurs due to new retinal breaks occurring in either normal retinal areas or adjacent to retinal burns, and this particularly occurs when posterior vitreous detachment is not yet complete. But early failures following treatment of HSTs can occur either due to inadequate therapy or spread of subretinal fluid before adequate chororetinal adhesion takes place. So new retinal breaks can occur after prophylactic therapy due to either persistent pre-existing vitreoretinal traction at the site of treatment if treatment is excessive, or due to treatment-induced vitreous changes causing vitreoretinal traction. Other complications of cryotherapy include epiretinal membrane formation, choroidal and vitreous hemorrhage, Addis pupil, disruption of blood-retina barrier, and corneal and lens burns. Very rarely, scleral rupture can occur following cryotherapy in an eye with a staphyloma. In a patient at an increased risk of RRD, counseling and follow-up with or without prophylactic treatment include recognizing symptoms of PVD, which include photopsias and/or increased floaters, regular self-examination of visual field of either eye separately, reporting immediately when symptoms or loss of field is detected, and periodic follow-up, usually every 2 to 4 weeks. 4 to 8 weeks after initial presentation, if flashes and floaters are stable or improving, risk of new retinal tears is said to be low. And for symptomatic patients presenting with significant vitreous hemorrhage precluding complete retinal examination, USG-B scan may help to detect HST or rule out RRD, and these patients may be advised bed rest with elevated head position and bilateral patching for a few days to facilitate settling of the vitreous hemorrhage till visualization of the retinal break is possible, else early vitrectomy needs to be considered in these patients. Peripheral retinal degenerations which are not associated with an increased risk of RRD include paving stone or cobblestone degenerations, which are discrete yellowish-white areas in the peripheral retina, either singly or in groups, as seen here in these two color photographs. They are most commonly found in the inferior quadrant and are more common in older individuals. Peripheral cystoid degeneration can be either typical or reticular. Typical peripheral cystoid degeneration appears as zones of microcysts in the far peripheral retina, usually located at the bases of the dentate processes, and they are found in almost all adult eyes. Reticular peripheral cystoid degeneration appears as a linear or reticular zone of cysts along retinal blood vessels, as seen here in this photograph. Although they are found in only 20% of adult eyes, they are almost always located posterior to zones of typical peripheral cystoid degeneration. Unlike typical peripheral cystoid degeneration, reticular peripheral cystoid degeneration may progress to the reticular type of degenerative retinoschisis. White without pressure, as seen here in this clinical photograph, is a sharply demarcated area in the region of the vitreous base and ora serrata which appears white without indentation, and in this area the choroidal markings are almost obscured. Osity of an area with white without pressure shows hyperreflectivity of outer retina without vitreous traction. Dark without pressure, as seen here in this clinical photograph, is a well-defined flat brown area usually located in the equatorial and peripheral retina. Osity through an area with dark without pressure shows hyporeflectivity of the outer retina. White with pressure is milky white appearance of a geographic area of retina with scleral depression which otherwise appears normal. Snowflake degeneration is an inherited vitreoretinopathy which we have discussed in the previous session. Pars plana cysts, as seen here in this clinical photograph, appear as clear fluid-filled, smooth cystic structures located anterior to the ora serrata. Pearl degeneration of peripheral retina appears as a white glistening bead-like opacity on the retina, typically at the tip of a dentate process, and drusens can also occur in the peripheral retina. To recap the salient points, retinal breaks and certain vitreoretinal precursor lesions predispose to the occurrence of rhegmatogenous retinal detachment. Retinal breaks are full-thickness defects in neurosensei retina and include retinal tears and retinal holes. Retinal tears can be horseshoe tears, operculated retinal breaks, giant retinal tears, and retinal dialysis. Vitreoretinal precursor lesions include lattice degenerations, cystic retinal tufts, meridional folds, and degenerative retinoschisis. HSTs occur due to vitreoretinal traction, which pulls a flap of retina anteriorly but does not detach it from the rest of the retina. It typically occurs at the posterior edge of the vitreous base, and the pull of the vitreous on the retina causes symptoms such as photopsias and increases the risk of RRD. Presence of vitreous hemorrhage and pigmented cells in the vitreous cavity increase the chance of a retinal tear being present in the eye. A giant retinal tear is a similar lesion, but the break extends for more than 3 clock hours circumferentially. In an operculated retinal break, the flap of the retina is detached entirely from the remaining retina and floats in the vitreous cavity just above the retinal break. In a retinal dialysis, the break occurs at the ora serrata and the vitreous remains attached to the retina posterior to the break. Lattice degeneration is a well-defined linear region of retinal thinning with overlying liquefied vitreous and adherent vitreous along its edges. Atrophic holes can occur within the lattice degeneration, which infrequently may lead to slowly progressing RRD in young myopic eyes. Retinal tears associated with lattice degeneration usually occur at its posterior and lateral edges. Retinal breaks and RRDs occasionally may occur from cystic retinal tufts, posterior edges of meridional folds and enclosed ora base, and degenerative retinoschisis. Risk factors for retinal breaks and subsequent RRD include vitreoretinal precursors, myopia, history of RRD in contralateral eye, family history of RRD following cataract surgery, following ocular trauma, certain inflammatory entities such as acute retinal necrosis and cytomegalovirus retinitis, hereditary vitreoretinopathy such as Stickler syndrome, male gender, and attached or incompletely detached posterior vitreous cortex. Definitive indications for prompt therapy for prophylaxis against RRD include symptomatic eyes with HST or operculated retinal break with vitreous attached to the retinal tear. Prophylactic treatment is strongly recommended for HST in non-phakic fellow eyes of eyes with RRD, precursor lesions in asymptomatic phakic or non-phakic fellow eyes of eyes with GRT, subclinical RRD, and eyes with hereditary vitreoretinopathies. Prophylactic treatment to reduce the risk of RRD entails creating a coretinal adhesion in the attached retina, completely surrounding the retinal break and vitreoretinal precursor lesion with cryotherapy or laser photocoagulation. Particular care needs to be taken to thoroughly treat the anterior margin of an HST and the lateral and posterior margins of a lattice degeneration. Partial adhesion following cryotherapy occurs after 5 to 7 days but almost immediately following laser photocoagulation. Complete effect following either procedure requires 3 weeks to occur. Unlike laser photocoagulation, cryotherapy can be performed through mild to moderate vitreous haze, and cryotherapy allows treatment of far peripheral anterior regions of the retina, but post-operative periocular swelling, breakdown of blood-retina barrier, and dispersion of RP cells into the vitreous cavity are more common with cryotherapy than with laser. Excessive laser photocoagulation can cause rupture of Bruch's membrane, choroidal hemorrhage, and retinal breaks. Other complications of prophylactic therapy include failure of therapy either due to inadequate therapy or occurrence of new retinal breaks elsewhere or at site of treatment, epiretinal membrane formation, and accommodation palsy and or Addis pupil. Patients at risk of RRD, whether receiving prophylactic treatment or not, need to be counseled about symptoms of posterior vitreous detachment, routine self-monitoring of peripheral visual fields, following up regularly, and reporting promptly when symptoms or visual field defects are detected. Thank you for listening.